we are discussing about the ophthalmic anesthesia. So we will give you some highlights and some difficulties faced by the ophthalmologists during the surgery under anesthesia. So we are trying to make it more streamlined for ophthalmologists. So the first talk is by Dr. Shalini Subramanian. She is a dear junior from All India Institute of Medical Sciences. So she is working in Narayan Netralaya as a consultant for last so many years. So she will talk about the pre-operative management investigation and how to do it right. Over to Shalini.
Thank you, ma'am. Okay. Good morning. Greetings from Narayan Netralaya and the Garden City of Bangalore. And for those who have so graciously come to our morning session on ophthalmic anesthesia, I promise to make my talk on pre-surgery optimization of pre-existing disease for eye surgery, short, crisp, and practice-oriented. For the rest of the talk, I will deal with adult patients posted for elective eye surgery under regional anesthesia. The consensus, guidelines, and evidence is quite robust with respect to cataract surgery, but I will also touch upon other ophthalmic specialties like vitreoretinal, glaucoma, orbitochloplasty, squint, as and when they are different or pertinent or available. Now, when we talk about eye surgery, there are certain merits as well as challenges involved in it. The advantages are that they do not cause too much of physiological stress, no major fluid shifts, no major blood loss, and amenable to being done under regional techniques as a day case surgery, so that there is minimum interruption of their daily routine with respect to diet or drugs. But it also has certain challenges in that the patients may be elderly, frail, multiple coexisting disease, polypharmacy, and often they are done in ambulatory surgery centers or standalone centers with limited access to medical or cardiac critical care. And pre-surgery optimization means stabilizing the perioperative or surgical risk, that is, with an aim to reduce the morbidity and mortality due to that surgery in that patient. And these perioperative and this pre-operative optimization or targets may be slightly different from population or primary care targets, in which the aim is to reduce long-term morbidity. And these guidelines, numbers, targets have been given by various anesthesia as well as ophthalmology organizations. We will look at them in the Indian context also. Now, the most common disease that probably existent in these patients presenting for eye surgery is hypertension. It is also the most common reason for postponement or cancellation on the morning of surgery. Now, Perioperative Quality Initiative, which is a multidisciplinary international organization that studies and releases consensus statements on issues in perioperative medicine, states that no patient should be cancelled just for a BP value. So is there a cutoff or threshold value in the preoperative period or on the morning of surgery below which it is safe and above which it is risky to go ahead with elective surgery? Well, there is no absolute number, but literature does give an arbitrary number, and this number is 180 by 110 millimeter mercury. Once again, because the number is arbitrary, I will not repeat this number again and again, and just call it a severely elevated BP. And any BP above this is called that patient is said to have a hypertensive crisis. Now, this hypertensive crisis or this high BP, severely elevated BP, is associated with signs of acute target organ damage like acute pulmonary edema, dyspnea, inability to lie supine, volume overload, acute kidney injury, or acute encephalopathy, acute confusion. Then elective surgery is a definite no-no, and the patient has to be immediately referred to medical care for intravenous antihypertensives and invasive monitoring. On the other hand, the same severely elevated BP, if it is not associated with any such signs of acute target organ damage, then that is called hypertensive urgency, which still has the risk of becoming a hypertensive emergency if not treated. Now, if simple remedial measures like giving anxiolysis or giving the missed dose of antihypertensive, which they may have missed due to any kind of NPO orders, can bring it to safe level, then we can go ahead with surgery on that day. Otherwise, it is better to defer and refer them to their primary care physician, because generally hypertensive urgency states gives us around 24 to 48 hours time to lower the BP. However, acute lowering of BP just to reach one target level is neither safe nor recommended. One word I would like to add, that certain surgeries like glaucoma surgery or lacrimal or orbital surgery or DCR, hypertension is sometimes perceived as a risk of intraoperative or postoperative bleeding. And in these patients, when it is better to impress upon them at the OPD level itself, either ophthalmology OPD or the PSC clinic, about the importance of home monitoring of BP to avoid undue delay or cancellation or confusion on the morning of surgery. The next common coexisting disease is diabetes, which is a state of chronic hyperglycemia. And hyperglycemia, we know from other literature related to cardiac or non-cardiac surgery that it has a potential risk of increased postoperative inflammation, delayed wound healing, as well as the surgical site infection, which in ophthalmology would mean the dreaded endophthalmitis. However, there is no definitive evidence linking hyperglycemia with any of these complications in eye surgery. Still, nevertheless, majority of ophthalmologists and anesthesiologists would like to have stable glycemic levels in the perioperative period. Once again, are there any magic numbers? Let's see. So if a diabetic, best is to identify optimization at the clinic level itself, either at the ophthalmology OPD or at the PAC clinic. If a diabetic patient comes and he has glycemic records, if he has done any kind of monitoring of fasting and postprandial sugar levels, or nowadays many of them come with continuous glucose monitoring patches, you can have a look at their app, and if the levels are consistently below 200 mg%, it's safe and good to go ahead with scheduling them for elective surgery. Or if they have a recent HbA1c which gives the mean glucose level over 3 months, and that is less than 8.5%, once again it's good to post them for elective surgery. High HbA1c levels, we never wait for them to normalize. However, if it is identified at this preoperative level, they are referred to the diabetologist who alters the anti-diabetic drugs, and once the fasting and postprandial are less than 200, we can go ahead with elective surgery. So if this exercise has been done religiously, then it is easy to make decisions on the morning of surgery. So what are the safe sugar levels on the morning of surgery? Now, definitely if it is associated with any kind of metabolic crisis, which may occur at levels above 250 mg%, then we would probably not like to go ahead with surgery. The safe level on the morning of surgery is given by various guidelines, including anesthesia and ophthalmology guidelines, to be 200 mg%. Some say 180 mg, some 200, some refer to as 12 millimoles per liter, which translate to 216 mg%. So we can make a general rule 200 plus or minus 10% if the preoperative exercise has been done properly. And this is the preprandial or fasting level. What about cataract surgery patients who often have their breakfast, their anti-diabetic drug, and then come for surgery? In them, if once again the preoperative stabilization has already been assessed, we could give them the benefit of doubt on that day, assuming that the increase in sugar level is probably due to acute stress or missing any of their anti-diabetic medication, in which case, once again, we can allow a 10% margin for them. Another note is that diabetic patients, it's best to post them early in the list to avoid prolonged starvation, dehydration, or hypoglycemia. Now, for cataract surgery, the perceived cardiac risk is less than 1%. In fact, it is only around 0.01%. And so patients who have chronic coronary artery disease, who do not have any new onset chest pain, dyspnea, or peripheral edema, and who can lie supine for the expected duration of surgery, it's good to go ahead with cataract surgery. Cataract surgery can also be scheduled 4 to 6 weeks after acute coronary syndrome, or even 30 days after percutaneous intervention. This is specific for cataract surgery, 30 days after percutaneous intervention with stenting, provided we do not stop the dual antiplatelet drug. Now coming to this eternal question of how to manage antithrombotic drugs in the perioperative period for patients presenting for eye surgery, it is a constant balance between the yin of the risk of surgical bleeding and the yang of the risk of systemic thromboembolism. But with better understanding of thromboembolic risk and improvement in surgical instrumentation, we have with every passing year, with more evidence coming up, we have more consensus and less controversies. And if we had to search for a formula to find the zone of safety, it has two variables. One is the bleeding risk and the other is the thrombotic risk. Now, the risk of surgical bleeding in eye surgery depends. Guidelines that refer to eye surgery as just one line in their entire document may not be exactly pertinent, because even within the various eye specialties, depending upon the complexity of the ocular pathology, invasiveness of surgery, type of anesthesia, and other coexisting diseases like renal or liver impairment and hypertension, the surgical bleeding risk may differ. And for thrombotic risk, there are various scores. The commonest is the CHAD score for atrial fibrillation, and there are other scores which cardiologists use for coronary artery stented patients. Now, before we go to the actual clinical scenarios, let us see which are these antithrombotic drugs. They can be either antiplatelet drugs or anticoagulants. anticoagulant drugs. Antiplatelet drugs are either aspirin or thienopyridine analogs, which are clopidogrel, ticagrelor, or prasugrel. They are all inhibitors of platelet aggregation, and they are used for prevention of stent thrombosis, or secondary prevention of stroke, or primary or secondary prevention of myocardial infarction or peripheral arterial disease. And if both aspirin and clopidogrel or ticagrelor are used in conjunction, then that is called dual antiplatelet therapy, which is particularly important in preventing stent thrombosis in the first 6 months after percutaneous intervention. With regards to anticoagulants, they inhibit clot formation, and the traditional one is warfarin or coumarin, which is acetone, which is a vitamin K antagonist. This still has an indication in the area of mechanical valve disease and valvular-related atrial fibrillation. All patients on warfarin will have a target INR which their cardiologist would have informed them about, and we need to be aware of this therapeutic INR for that patient for that condition. And, but in several other clinical conditions, warfarin has been superseded and replaced by direct oral anticoagulants or novel oral anticoagulants, of which there are 2 types, thrombin inhibitors and apixaban. So these are used in non-valvular AF and prevention and treatment of venous thromboembolism. So once again, we have to balance the thrombotic versus bleeding risk. Now, it becomes very simple. If the bleeding risk of that eye surgery, which are those eye surgeries, I will tell in the next slide.
Dr. Shalini, your time is up.
Just a minute, ma'am, this is the last slide. If it is low, then we go ahead with anticoagulant and antiplatelet therapy. If the bleeding risk is high, then and the thrombotic risk is low, 80% of the time we will be able to discontinue the drug if the primary condition for which the drug was started has now been stabilized. There is a very small cohort of patients in whom the bleeding risk is high and the thromboembolic risk is high, in which the decision to go ahead, we can take any of the 3 decisions. One is postpone the surgery until it is safe, or second, because surgical bleeding is still a gray area with many evidence suggesting that it is not true, then we can re-explore the risk by optimizing other factors which may increase bleeding, like using subtenons anesthesia, or using a 25 or 27 gauge vitrectomy, or controlling BP well. And there is a very, very small section of patients who might require bridging therapy. Now, cataract, of course, the consensus is clear that it is a low risk of bleeding. Peribulbar anesthesia also causes only non-site-threatening hemorrhage, that is lid ecchymosis or subconjunctival hemorrhage. High-risk surgery, where the evidence is not robust, includes retinal diseases with diabetic vasculopathy, glaucoma surgery, and DCR. So in conclusion, I will say please be aware of the perioperative goals and the recent literature, and it's better to have written guidelines for your institute after taking into concern all the specialties, and I hope this working knowledge was useful to you, and use this knowledge to counsel the patient about primary targets rather than cancel the case on that day. Thank you so much.